The effusion fluids include pleural fluids, pericardial fluids, and peritoneal fluids. The term paracentesis is the percutaneous puncture of body cavity for aspiration of fluids. Percutaneous puncture of a body cavity to aspirate a fluid. It is what we call paracentesis, of course, through the skin. These effusion fluids can be corrected through paracentesis, and because they are various body cavities, so then we call them effusion fluids. But specific terms can be used depending on which cavity is punctured. It can be a thoracic cavity, and we in fact correct through thoracentesis, which is a surgical puncture of the chest wall into the pleural cavity to correct pleural fluids. So thoracentesis is to collect pleural fluids, whereas pericardiocentesis is to correct a pericardial specimen from pericardial cavity, and peritoneocentesis is abdominal paracentesis, which is of course to correct peritoneal fluid from cavity. The term ascites, of course, means effusion fluids in the peritoneal cavity, and also which we call ascitic fluids, and is simply another name of peritoneal fluid. Ascitic fluid or peritoneal fluid are the same, and the correction of effusion from body cavity is invasive surgical procedures, which must be performed by a physician using sterile techniques. So unlike the CSF synovial fluid correction or serous fluid correction from effusion in pleural, pericardial, and peritoneal cavity, in fact, it gives large volumes of fluids, because in fact, pleural fluid can be very large, pericardial fluid as well as peritoneal fluids, unlike CSF and synovial fluids, where we have to correct a certain limited amount of fluids. At times, additional or repeat puncture procedure are necessary to remove reoccurring effusion from a cavity for therapeutic purposes. Sometimes we can even perform therapeutic paracentesis in order to remove excess body fluids from those cavities. So normally serous fluid don't contain blood or fibrinogen, but a traumatic puncture or hemorrhage can result in bloody and clotted fluids. Otherwise, effusion fluid don't really contain fibrinogen. So therefore, to prevent clot formation which entrap cells and microorganisms, tube containing sodium heparin or liquid DDTA are used. Remember that also the same tubes are also used for correction of most other body fluids, including synovial fluid that we discussed, as well as, of course, amniotic fluid. You can use sodium heparin or liquid DDTA. So in contrast, serous fluid for chemical testing is placed into non-anticoagulant tube or red top tube, which also will allow clot formation with fibrinogen when it's present or when blood is actually present. So in order for us to allow clot formation, in case fibrinogen is present in the fluids, we should of course place these body fluids into red top tube in order to allow clots. So serous fluid should be maintained at room temperature and transported to the lab as soon as possible, then in order to eliminate any chemical change, cellular degradation, as well as bacterial proliferation. But as a common rule for body fluids, never refrigerate body fluids for laboratory testing. Don't refrigerate them. But serous fluids, specimen that are intended for cytology, we can actually refrigerate at 4 degrees in order to avoid further degradation of cells. And as you remember also that cerebrospinal fluid that is in cytological studies, we can sometimes refrigerate it if that's need. So it can be refrigerated. So, but a blood sample must also be collected along with the body fluid in order to allow compilation studies of chemical composition of effusion with that of the patient plasma to enable classification of effusion. So, in order to classify effusion fluids as transudate, exudate, chirus, or pseudochirus, we must also correct plasma in order to make room for comparison, which assist in diagnosis and treatment. So also when you collect plasma and body fluid as well together, you must ensure that handling conditions are the same in order to eliminate any variations. So what is transudate and what is exudate? Effusions are classified as transudate or exudate, and this classification is based on the appearance leukocyte count as total protein count, lactate dehydrogenase activity, glucose value, bilirubin concentrations, and so on. So, but because of the overlap of categories, no single parameter is really enough to differentiate transudate from exudate in all patients. So there would be a combination of in order to classify a transudate or exudate. So classifying effusion as a transudate or exudate is important because this information will assist in establishing treatment and the cause of that effusion. Transudate is normally a result of systemic disease, but without any inflammatory process. For example, hydrostatic pressure or decrease in plasma oncotic pressure. This can lead to the accumulation of fluids which are transudate. So they are not normally because of any kind of inflammation. That is like problems of hydrostatic pressure, movement of fluids between tissues. This can happen in most cases without enough enough albumin, because albumin in fact ensure oncotic pressure is maintained. Or of course, oncotic pressure is of course what you call hydrostatic pressure. These changes are non-inflammatory, of course, and they are associated with the congestive heart failure, hepatic cirrhosis, and also nephrotic syndrome. This is, you remember what we call hepatic cirrhosis and nephrotic syndrome. Both of them are associated with the decreased levels of albumin protein, right? Both nephrotic syndrome and hepatic cirrhosis are associated with hypoalbuminemia. So in this term, we have said hypoproteinemia, but of course, we are dealing with albumin here. So once the effusion has been identified as a transudate or exudate, we can then take action. So if it is a transudate, no further laboratory testing is necessary. But of course, in contrast, when it is transudate, it can be exactly from a certain inflammatory process that increase permeability of the capillary endothelium in the parietal membrane or decreased absorption of fluids by lymphatic system. So many other disease processes can also can also cause the accumulation of exudates, including infections, neoplastic disorders, systemic disorders, trauma, and many other conditions that create inflammation. So in such case, of course, when the fluid is identified as an exudate, there must also be additional lab tests, for example, microbiological studies, in order to identify a pathologic organism associated with that fluid, because the fluid, of course, is a source of a certain inflammatory condition, which also may be triggered by microbiological agents. So as well as cytological studies in order to identify if any neoplastic transformation has taken place or any neoplastic metastasis has taken place. So that can actually direct us to analyze the specimen further in order to identify any pathologic process, malignancy, microbiological process, or any other process. Unlike pleural and peritoneal effusion, however, Pericardial effusion usually are not classified as transudate or exudate. So among these three effusion fluids that we are talking about, in fact, we can classify pleural and peritoneal effusion as either transudate or exudate, but pericardial effusion is neither classified as transudate nor exudate. So most often, pericardial effusion results from pathologic change. Always, when it is seen, it is in fact a problem of pathologic change. It's not just like a normal problem. So the majority of pericardial effusion could be considered as exudate. So mostly pericardial effusion are classified as exudates because mostly they are associated with the pathologic processes. So you can say that pericardial fluid is in a transudate. That cannot make sense. So parameters that we normally consider to differentiate between transudate and exudates, even though we are going to look at them one by one down here, but causes of both transudate and exudate can be different. For example, transudate can be caused by hydrostatic pressure, whereas exudate can be associated with maybe capillary permeability or decreased lymphatic absorption. And the clarity of transudate is always clear, whereas most exudates is always cloudy, and color is in fact pale yellow for transudate, but exudates will have variable colors. For example, yellow color, yellowish color, greenish, pink, and red colors will be associated with the exudate, and spontaneous cell clots can happen most oftenly with exudates, while in transudates there is no spontaneous clots. So WBC in transudate could be even less than 1,000 cell per microliter, but in most cases, of course, with the exudates, it would be even greater than 1,000 cell per microliter. So differential counts, in fact, mononuclear cells are found most commonly with the transudates, whereas exudates, of course, you find that most cells are neutrophils or polymorphonuclear cells. If you want to classify them, then you find that more than 50% are neutrophil, so then that can be classified as a exudate. But you remember that no single parameter can normally conclude, because a parameter can in fact produce overlapping results among patients, but you can use either one or two or three parameters in order to differentiate. So bilirubin is of course high in exudates, glucose is of course less in transudates, whereas it is in equal volume, in equal levels or equal concentration to that of serum. Total protein must be of course high in exudates, but of course it can be low, but of course not a pathologic low, but low in transudates comparing to serum. And lactate dehydrogenase activity is of course very high in exudates, because we know that exudates is associated with many issues, for example, malignancy and also bacteria, and most of them you find that ADH concentration is high. Now, physical examination of our effusion fluids. So transudates are normally clear fluids, pale yellow to yellow color, and also viscosity is similar to that of serum, but transudates don't contain fibrinogen and they don't clot. But in contrast, exudates, they are normally cloudy and vary from yellow to green to pink to red, and they may even show a shimmer or sheen to them. You know sheen, how it looks like? It's like a creamy layer of a color. So for example, green sheen or yellow sheen, depending on the color of that shimmer. So because exudates are contain fibrinogen, they can form clots. So they require anticoagulants in order to avoid clotting, in case we want to identify cells in the exudates. So a cloudy paracentesis fluids indicate the presence of large number of leukocytes and of course other cells, child and lipids. So in pleural or peritoneal fluids, when it looks like milk or milky appearance, after centrifugation, it indicates the presence of chyle. So chyle is emulsion of lymph and chylomicrons in the effusion. So that effusion we can say it contains a chyle or chylomicrons and lymph in emulsion or make a mixture of chylomicrons and lymphs. A chylous effusion is caused by obstruction or damage to the lymphatic system, of course, and in the pleural cavity, this can be caused by tumor or lymphoma or damage to the thoracic ducts and also accidental injury during surgery. This can cause also, of course, the drawing of the lymphs and the chylomicrons, and then they will accumulate as a chylous effusion. So chylous effusion in the peritoneal cavity can also occur as a result of obstruction of the lymphatic fluid drainage with the hepatic cirrhosis and portal vein thrombosis. For example, in case of portal vein thrombosis and obstruction of the lymphatic fluid drainage, this can accumulate chylous fluids in the peritoneal cavity, and peritoneal fluids or ascitic fluid is said to be chylous fluids in this incident. But chronic effusion, as it is normally seen in rheumatoid arthritis, tuberculosis, and also myxedema, can be similar in appearance because of the breakdown of cellular components and also a high concentration of cholesterol. So because of the visual similarity, these fluids that is chronic effusion fluids, because of some conditions, for example, rheumatoid arthritis and tuberculosis, that fluid that is formed, it is not actually a chylous fluid. It is called pseudochylous fluid because it normally look like chylous, but because of the content is not the same, is different, so then we can call it pseudochylous. So pseudochylous are differentiated from true chylous effusion fluids by their lipid content. So, for example, triglycerides and chylomicron, right? So, in case for us to conclude this is a chylous effusion, it must show elevated triglyceride levels above 110, and also chylomicron must be present. But in pseudochylous effusion, there is very low triglycerides, which is less than 50, but there is no chylomicrons at all. So that's how we can classify it as pseudochylous. And remember, the source of pseudochylous is in fact a source, or it can accumulate as a result of chronic inflammatory conditions, for example, rheumatoid arthritis and tuberculosis. So if it accumulates anywhere because of this, as a result of any systemic or any organ-specific inflammatory condition, for example, rheumatoid arthritis and tuberculosis, it will not be, we cannot find chylomicrons because it is not a problem of maybe blockage of portal vein or lymphatic drainage or whatever. So because that could actually cause chylomicron accumulation in the fluids and also, of course, other lipids. But here, there's nothing like that. So what happened is only the formation of fluid because of chronic chronic inflammatory processes. So that is not really a chylous fluid, but it is a pseudochylous fluid. And pseudochylous fluid does not contain chylomicrons, and it contains very low triglycerides levels. So blood can be present in a transudate and even in exudates because of trauma as well, traumatic paracentesis. But if blood is homogeneously distributed in the fluid does not clot, and the patient has hemorrhagic effusion. If, for example, you see blood is not clotting, but the fluid is not clotting, but blood is actually distributed homogeneously. So, which means the fluid looks red, but without precipitations or sediments of blood. Because, for example, after maybe placing a fluid somewhere for some minute, and you find that the sedimentation or precipitation of blood at the bottom of the tube, that is not hemorrhagic effusion, because in fact blood must be very well homogeneously distributed, so which makes it in fact a hemorrhagic effusion. So now, microscopic examination of our effusion fluid in lab. So in fact, the microscopic examination of pleural, pericardial, and peritoneal fluids may include count of RBC and also WBC, as well as differential count and cytological studies, as well as identification of some crystals may present in the specimen. So, and also, if the specimen is meant to be taken to microbiology lab, so gram stain must also be performed in order to screen for any present microorganism. So as with other body fluid, of course, cloud effusion must be diluted in order to allow cell counting, and you can dilute using normal saline. You know, cell counting, of course, can be performed using a hemocytometer or an automated analyzer. So we must use normal saline to dilute our effusion fluid in order to allow distribution of cells and enable us to count using hemocytometer. You know, hemocytometer we just have to multiply using formula and considering, of course, dilution factor. Depending on which dilution factor we used, maybe you can use here 1/20 or 1/100, depending on the on the cloudiness level of the fluid. You can use, maybe you can use 20, or you can use 100 dilution, 1/100 or 1/20, depending. Then we can use that one to calculate total cell counts. You know the formula we use: cell counted times the dilution factor over total cell count times depth, so which is 0.1. So we can use the same formula in order to get to the correct count. So total cell count can be performed, of course, even though the total cell count has a little or no diagnostic value in these fluids. But with the pericardial fluids, when WBC are increased to level of greater than 1000 cells per microliter, this is suggestive of pericarditis. But when RBC counts or hematocrit assist in identification of hemorrhagic effusion, for example, with hematocrit and also RBC of the fluid, that can lead to identification of hemorrhagic effusion. So, but with the pleural fluid, and of course, you remember that pleural fluid is collected from the lungs, cavity of the lungs, right? Sometimes people confuse these fluids. Sometimes we don't differentiate between peritoneal fluids, pleural fluids, and pericardial fluids. In fact, of course, pleural fluid is collected from the back of the lungs. There are like cavities. There's a cavity there. There's a cavity which covers the lungs. Sometimes fluid accumulate there. We can collect, of course, collecting pleural fluids, which is a paracentesis of pleural fluids. And then pericardium, of course, this is pericardial cavity, which can also accumulate fluids because of pericarditis. And you can collect fluid from the heart cavity, and you can also collect fluid from peritoneal cavity, which is like abdomen, right? Peritoneal cavity for people with ascite. So in case of peritoneal fluid, when the cell exceed 500, then you can also, of course, in fact, you can diagnose bacterial peritonitis. But when, of course, 50% and above are neutrophils. So differential count can be somehow valuable in clinical lab in order to establish diagnosis. Pleural fluids, neutrophil predominates in about 90% of effusion, which is caused by acute inflammation. Of course, it will be exudates. For example, exudates pleural fluids. Normally, you could see that neutrophils are normally have predominated about 90% of the cells. So, but lymphocyte predominates in 90% of effusion caused by tuberculosis, neoplasm, and systemic disease. For example, when you find that most of the cells there are just lymphocytes, so then you suspect the problem. Maybe one problem could be neoplasm, tuberculosis, or systemic disorder. Similarly, peritoneal fluids, when neutrophil, in fact, they also predominates 20% and above, that can also be in exudates bacterial infection of the peritoneal cavity. So, peritoneal transudates and in exudate caused by decreased lymphatic absorption, tuberculosis, neoplasm, lymphatic obstruction. In fact, here lymphocyte predominates, but not neutrophils. In exudate caused by decreased lymphatic absorption, that can be problems with tuberculosis, neoplasm, and lymphatic obstruction. So here, lymphocyte will predominate among other WBC. Pericardial fluids, this also differential count is rarely performed because always pericardial fluid is normally regarded as exudate. Whenever it is corrected, it is always in exudate, and counting cells is normally does not normally give any clinical significant result. Different cells are found in pleural, percardial, and peritoneal fluids, and they include neutrophil, eosinophil, lymphocyte, monocyte, macrophage, plasma cell, mesothelial cell, and also malignant cells. So malignant cells, of course, they are sometimes metastatic cells from other neoplastic disorders like leukemia, lymphomas, and many other tumor neoplasia. So macrophage can be seen with large vacuoles such that the nucleus is pushed against the cell membrane, and when you see them in these fluids, they are called signet ring macrophage. Signet ring macrophage, as you can see how they look like. You find them as signet ring macrophage, and they are found with a nucleus pushed toward pushed towards cytoplasmic membrane, right? This is a nucleus, and this cell, when it is seen, it is called a signet ring macrophage. So even though sometimes it is rare, but also lupus cells can also be seen. They are called lupus erythematosus cells. They can also sometimes be seen, and when they are identified, they are normally associated with the systemic lupus erythematosus. Those are called lupus cells, and those cells are in fact, excuse me, just 1 minute. If those ones they are seen, they are normally associated. They are in fact neutrophils, but with the phagocytosed materials. The phagocytosed materials, of course, in case of systemic lupus erythematosus, and those materials are just lupus materials that are homogeneous, and they may be present with patients suffering from systemic lupus erythematosus. So, for example, that's how they look like. Those are the systemic lupus erythematosus cells. Those are all neutrophil that phagocytosed those homogeneous mass or homogeneous content. So these are called lupus cells. So those are the complex. Of course, you know that systemic lupus erythematosus is an autoimmune disorders which is characterized by the accumulation or excessive complex formation, of course, because of antibody, antigen, and many other factors, and many other mediators, and many other products or byproducts from the process. So those can be digested by neutrophils, and those cells are called lupus erythematosus cells, or LE cells. So mesothelial cells that line the serous membrane are routinely stalled off and appear in the effusion. Of course, sometimes they will appear without any significance. Those are the mesothelial cells that line serous membrane. For example, mesothelial cells that may line peritoneal cavity or pleural cavity or pericardial cavity, sometimes they be seen in the fluids. So they are large with a light gray to deep blue staining cytoplasm, and the nuclei are eccentric with smooth regular nuclear membranes, and the nuclear chromatin pattern is loose and homogeneous, and one of the 3 nuclei may also be present. So this is how the cell look like. But mesothelial cells, they normally have abundant cytoplasm, and sometimes you may see them resembling plasma cells. So when they are seen, they also show evidence of phagocytosis because their plasma loose is blue color and they contain cytoplasmic vacuoles of various sizes. So because they can vary in appearance, so they can appear singly or they can appear in clumps, and can be multinucleated and can even show reactive or degenerative changes. So mesothelial cell can be difficult to differentiate from malignant cell and macrophage. So it is very difficult to differentiate mesothelial cell, even though the presence of mesothelial cells is normally non-significant. It is non-clinical significant, but it can be difficult to distinguish them from malignant cells and macrophage. So, but of course, malignant cells are also seen in pathology conditions, but macrophage may not be so significant. I think someone asked that question, even though I didn't see the message clearly, but she was asking the clinical significance of macrophage in the fluids. In fact, the macrophage can be also seen in various conditions. For example, in inflammatory conditions, macrophage are also present, and also many other non-bacterial infection or non-bacterial inflammatory process, for example, tuberculosis, for example, also neoplastic transformations, for example, other inflammatory conditions that are associated with these cavities, but other than bacterial infections, because in fact the neutrophils are always responsible for bacterial infection previously at the first time, and then macrophage will also be present. But macrophage cannot be specific because macrophage, according to their function, which is housekeeping, macrophage they have function of housekeeping. So housekeeping means any serious problem around macrophage will be present. So that's why you cannot say that macrophage are specific for this condition. Macrophage can also be found in bacterial infection. At the same time, they can also be found in other non-bacterial inflammatory condition, for example, malignancy, for example, tuberculosis, HIV, and so on. So those are the macrophage. If the question was just about macrophage, but those are what you call mesothelial cells. The mesothelial cells may look like plasma cells with abundant cytoplasm, as you can see, with abundant cytoplasm, but sometimes they can be multinucleated, which can normally help you differentiate them from normal plasma cells, because normal plasma cell, they are not really multinucleated in this way. They're not multinucleated. So plasma cell are seen, for example, they would look like this, but plasma cell, they are also known to have abundant blue cytoplasm because of the process going on, but they are not really multinucleated. So malignant cells, in fact, are common in patients with a neoplastic disease, and these cells can be monomorphic, which all cells look alike, or pleomorphic with the variation in morphology. So neoplastic cells, malignant cells that are seen in effusion fluids, because they arise from different neoplastic disorders, they can't have the same morphology, because some of them arise from lymphoma, metastatic lymphoma, metastatic leukemias, metastatic tumor cancers, or tumor malignancies. So they can't have the same, or they can't exhibit same morphologies. So in fact, some of the characteristics of malignant cells, they tend to clump together, sometimes irregular in cell membrane or nuclear membrane, or sometimes jagged nuclear membrane. The nuclear chromatin is unevenly distributed. You find some openness. You find sometimes clampings in the nuclear chromatin, and they contain prominent and multiple nuclei with irregular membranes. So you find they're also different, and they really exhibit significant irregularities. So the high nuclear cytoplasmic ratio can also be another thing. The high nuclear cytoplasmic ratio, and the cytoplasm may be basophilic and may contain vacuoles. So those are different malignant cells or metastatic adenocarcinomas. So like this, some of them are malignant cells. Malignant cells, especially adenocarcinoma in peritoneal fluids, adenocarcinoma in peritoneal fluids, it would show differences in sizes, in shapes, in architecture of these metastatic adenocarcinoma cells or malignant cells. Like they can be seen sometimes with even multiple nuclei as well. So, but also other features of malignant cells include multiple round cell aggregate. Sometimes they can they can appear in clumps or in balls, or they may even exhibit large cytoplasmic vacuoles and bizarre forms. So sometimes also they are seen in different ways. But also we should not forget also to mention that apart from these cells that are looking like this, even the normal malignant cells or malignant hematogenous cells, for example, in case of leukemia, metastatic leukemia, cells can also migrate to these fluids or cavities, and also lymphomas as well. So in that case, you would be able to see the cells, leukemic cells or leukemic blast cells, as well as lymphoma mature cells, like mature lymphatic neoplasms. Sometimes you'd see mature lymphocytic cells also appearing in these fluids, depending on the degree of metastasis. Finally, chemical examination of these fluids. In fact, because transudate does not require any further chemical analysis, but exudate always require further chemical analysis, as well as also microbiology to identify a causative agents of these fluids. So total protein and lactic acid dehydrogenase ratio can be used very well in exudate further assessment, even though no single parameter can be used to assess the disease or causing or a causative or a root cause of a certain condition, whether it is pleural or percardial or peritoneal. So, however, we can use fluid tests to classify effusion fluid as a transudate or exudate are in fact done together with determination of serum and serous total protein concentration and LDH activity. So we must have both of them together, serum and total protein concentrations. Serum and effusion fluid total protein concentration, as well as lactic acid dehydrogenase together in order to classify them accordingly. So from this value, then fluid to serum total protein ratio and fluid to serum LDH ratio can be determined, and we can determine them as total protein ratio as total protein in body fluid over total protein in serum, and LDH activity in fluid over LDH activity in serum. As we compare this ratio, then we can be able now to analyze and establish diagnosis. So if the ratio of total protein is less than 0.5 between fluid and serum, so then LDH ratio is also less than 0.6, the fluid is classified as transudate. So what does this mean? It means that protein in transudate, protein in the fluid, before we classify it as transudate, of course, protein in the fluid is less than that, very less, not just less, but very less than that of serum, because it is 0.5, right? It means because total protein in fluid is a numerator, but the denominator is total protein in serum. So which means that one in fluid is normally 0.5. So which means is less than half of that of serum. Then you can classify it as transsudates. But in contrast, when exudates are in fact suspected, you'd see that total protein ratio between fluid and serum is greater than 0.5. So you can now test both the specimen and quantitate protein and then calculate the ratio. If it is greater than 0.5 and if the LDH ratio is greater than 0.6, then this will normally classify the specimen as exudate. Then physician will be able to know what is going on after you have classified for them whether the specimen is a transudate or exudate. So after classifying the specimen as a transudate or exudate, then we can then of course use a other chemical test to evaluate, to do a further evaluation in order actually to try to identify the cause of that exudate production. So measurement of serum and serous fluid glucose concentration has in fact limited values, but if the serous fluid glucose is less than 60 mg per deciliter, then, or if the glucose difference between serum and fluid is greater than 30, then exudative process is also identified. For example, you remember that in exudates, glucose is always low, but in transudate, glucose is almost the same value as that of plasma. So now, in case glucose is less than 60, so it means there is a problem of excessive consumption of glucose, so which classify this as exudates, and most commonly, of course, a bacterial exudates or bacterio-inflammatory exudates. And also, when the difference between serum and fluid is greater than 30, so it means also it classifies it exactly as exudates. So only low fluid glucose levels are clinically significant but associated with rheumatoid arthritis, bacterial infection, tuberculosis, malignant neoplasms. But normal serum fluid glucose does not also rule out those conditions. Yes, sometimes we can say that low glucose is significant, but however, even if glucose is normal, we can also check other parameters. We can't rule out those conditions with low glucose, with the normal glucose in the fluid. So amylase is also performed. In fact, amylase can help us to determine serum and fluid amylase will be, of course, clinically useful because if serous fluid amylase value that is 2 times the serum value is associated with effusion caused by pancreatitis. For example, someone has got effusion caused by pancreatitis. For example, peritoneal or ascitic effusion caused by pancreatitis, you find that amylase is very high, or esophageal rupture, gastroduodenal perforations, and metastatic diseases, that in fact will increase amylase activity. So amylase, of course, is enzyme. We can't measure concentration of it, but you can measure activity of this enzyme. So when the activity is very high, at least 2 times that of serum, then we suspect serious conditions like pancreatitis, esophageal rupture, and so on. So finally, we can also quantitate lipids, of course, cholesterol, triglycerides, chylomicrons, in order to classify them, in order to differentiate between chylous effusion and pseudochylous effusion. So you know that identification of chylous effusion, so we must always identify or determine triglyceride levels in the effusion fluid. So serous fluid, when triglycerides is greater than 110, that immediately can classify this fluid as a chirus fluid or a chirus effusion fluid. But when triglyceride is less than 50 milligram, so then it means it can rule out these chirus fluids. So then if triglyceride is between 150 and 110, then we can do lipoprotein electrophoresis in order to identify chylomicrons. So because you know that chylomicron is present only in chirus effusion, but is not present in pseudochirus effusion. So then using those terms, you can then remember what causes pseudochirus effusion accumulation and what causes chirus itself. So there are different causes, because pseudochirus normally is associated with the chronic inflammatory conditions, for example, rheumatoid arthritis, but chirus is normally associated with the rupture and blockage of the lymphatic drainage and also other hepatic drainage, hepatic vessels, which leads to the accumulation of chylomicrons and triglycerides. So then, ruling out pseudochirus, we must always perform lipoprotein electrophoresis, and when there is no chylomicron, then you can classify this one as a pseudochirus effusion. So chirus effusion can be associated with the difference. For example, we have talked about them: neoplastic disease, obstruction of the lymphatic system, and tuberculosis, and so on. Whereas pseudochirus is caused by many chronic inflammatory conditions, for example, rheumatoid arthritis, and so on. So that's how we can normally, of course, use these lipids to classify between pseudochirus and chirus. And then finally we have pH. So pH can also be useful, but in fact pH less than 7.3, in fact, like for example with someone with pleural fluid, pH in pleural fluid is a problem. In fact, with the pleural fluid, an abnormally low pH value can help in identifying patients with paranemonic effusion. So paranemonic effusion is a very serious mnemonic effusion, which is associated with lung abscess, and this require a very aggressive treatment. This is exudates in the lungs that really associated with lung abscess. So it is called paranemonic effusion, and this one normally is associated with the acidic pH. So when the pH is less than 7.3, so despite appropriate antibiotic therapy, the replacement of drainage tubes is necessary for a resolution of the effusion. Otherwise, these can normally, when it is above 7.3, this can be actually resolved by antibiotic treatment. But otherwise, pH in the fluid, especially pleural fluid, can be very, very, very important, because this require very serious treatment for the paranemonic effusion clearance. Otherwise, pH in other body fluid, pH in other effusion fluid, pericardial or peritoneal, normally may have no clinical significance to establish the value of the pH for these two other body fluids other than pleural fluid. So thank you so much for being with me in this presentation. I hope you enjoyed it, and it is a really very nice presentation. So ours is just to share with you what we have, and in fact remind you that you have something to read, because sometimes we have package, but sometimes you may not remember that you have something to read, or you have something to know, or you have something to master. So that's why we always have presentations, in order for you to join and enjoy our presentation, and as we remind you that you have something to do, because it's not to teach you something new, but to remind you that you have something to read and revise and master. Thank you so much. All the best. I wish you all the best as you are preparing for your examination. So God bless you. See you tomorrow during the next presentations.